Hi everyone, it's Derek here from ADUMED. Today we will be covering AF, a topic that many find challenging. Here we will cover the key aspects of presentation, investigation, and an approach to management. So let's dive straight in. Let's start off by talking about how patients with AF may present. These patients will have an irregular pulse, and other symptoms may include the following. These are the 4 categories of AF. A first detected episode, recurrent AF, which is essentially 2 or more episodes of AF, paroxysmal AF, which is classed as recurrent AF that self-terminates spontaneously. This tends to last for less than 7 days. And permanent AF, which either cannot be cardioverted or is not suitable for cardioversion. We can investigate AF with an ECG. For suspected paroxysmal AF, the patients tend to need a 24-hour tape or an event recorder if episodes are less frequent than every day. Other investigations include blood, such as a full blood count, TFTs, LFTs, and U&Es. The last is particularly important if we think about how the body will be eliminating or excreting a given anticoagulant. An echo may be indicated, but only during the following circumstances. In cases of structural or functional heart disease, if there's a planned cardioversion, in order to ensure no clots, and lastly, if we need to balance the risks. For example, a patient who is at high risk of both stroke and a bleed. When we approach the management of AF, we can break it down into 2 main points. Firstly, we need to assess for stroke and bleeding risk. Secondly, we need to think about rate or rhythm control. So, starting with our assessment of stroke and bleeding risk, we can do this by using scoring systems such as CHA2DS2-VASc score. A score of 0 means no anticoagulant is required. A score of 1 in a male means that we can consider anticoagulation, but this same score in a female would mean no anticoagulation. A score of 2 in both male and females means we will be offering anticoagulation. Please see the link in the description box for a further breakdown of the CHA2DS2-VASc score. We can also use tools such as Orbit, which has replaced the Hasbled scale, to assess bleeding risk. Please see the link in the description box for further information. When thinking about anticoagulation, first-line anticoagulants are our DOACs, such as apixaban and rivaroxaban, but warfarin can be used if these are contraindicated. Examples include antiphospholipid syndrome and reduced creatinine clearance. After we've looked into the stroke and bleeding risk, the second part of AF management includes making a decision about rate or rhythm control. Rate control is always first line unless certain criteria are met. Patients that meet these criteria will instead have rhythm control. The criteria for rhythm control include new onset AF, if there's a reversible cause, in young patients, and in cases of heart failure caused by AF. If we have decided on rhythm control, these patients are referred for cardioversion, where secondary care will make a decision if this is electrical or pharmacological. If cardioversion fails, then the patient may have a left atrial ablation. In relation to rate control, treatment is either with a beta blocker, except sotalol, or a rate-limiting calcium channel blocker, such as diltiazem or verapamil. Digoxin is a possible alternative in people with non-paroxysmal AF if they do little or no exercise. If monotherapy is ineffective, then we can try any 2 of the following: a beta blocker, diltiazem, or digoxin. A key point to remember is that verapamil should not be prescribed with beta blockers due to a risk of hypotension and asystole. So, when do we refer in AF? Well, we do so in the following 3 conditions. An immediate same-day referral if the patient is hemodynamically unstable or acutely unwell, such as in fast AF. A routine referral can be done for rhythm control if, despite second-line management, the patient is still symptomatic or there is suspicion of structural or functional heart disease. We can refer to secondary care in cases such as paroxysmal AF so that a decision can be made on control strategy. So thanks for watching this video. If you found this helpful and would like to watch more videos like this, please don't forget to like, comment and subscribe, as this will really help my channel to grow.